All right, welcome everyone. In this session, we're going to tackle three huge topics in pediatrics that, let's be honest, often feel like they're in completely different worlds: rheumatology, genetics, and inborn errors of metabolism. Our goal here is to connect those dots, to make this stuff stick, not just for your exams, but for your real-world clinical practice. Look, I get it. It can feel like you're studying three totally separate subjects, right? I mean, how does a kid's swollen knee have anything to do with a complex pedigree chart, or an acutely ill newborn with labs that just don't make sense? It's a really common struggle, but if you stick with me, I promise you'll see exactly how these pieces of the puzzle actually fit together. So here's our game plan. We'll start by setting the stage with what I call the pediatric puzzle. Then we'll dive into the absolute highlights of rheumatology. After that, we'll decode some core genetic principles, learn a really systematic way to approach metabolic errors, and then at the end, we'll pull it all together in a super high-yield review. Okay, let's get started. Section 1, the pediatric puzzle. The whole point here isn't just about memorizing a bunch of facts from different chapters. It's about building a mental framework, a way of thinking. Because once you can connect the clinical patterns of rheumatology with the inheritance blueprint of genetics and the biochemical breakdowns of metabolic errors, that's when you'll be able to solve those really complex clinical cases that you're definitely going to see. Let's move on to Section 2. We're jumping right into pediatric rheumatology. Now, if there's one skill you need to develop here, it's pattern recognition. Seriously, don't get lost in all the tiny details. Just focus on seeing the big patterns. First things first, what do we actually mean when we say a child has arthritis? The definition is really precise, and you've got to know it. It's either obvious swelling or an effusion, which is just a fancy word for fluid collection in a joint. Simple. If you don't see that, then you need at least two of these three signs: a limited range of motion, pain when they move the joint, or tenderness when you actually touch it. That's our starting point for everything else. Okay, now this slide, this is a game changer. It massively simplifies your differential diagnosis. Before you even start thinking about specific diseases, just think about time. How long has this been going on? If it's acute, less than 2 weeks, you should be thinking septic arthritis or Kawasaki disease. If it's subacute, say 2 to 6 weeks, maybe it's reactive arthritis or even leukemia. And if it's chronic, lasting more than 6 weeks, well, now you're deep in the territory of juvenile idiopathic arthritis. This simple, time-based filter is your most powerful first step. Speaking of juvenile idiopathic arthritis, or JIA, please don't try to memorize every single detail about it. Just focus on the high-yield patterns. So you've got oligoarticular JIA. That's 4 or fewer joints, usually a big one like the knee. The absolute must-know fact here: it's strongly linked to asymptomatic uveitis, so these kids need regular eye exams, period. Then there's polyarticular JIA, affecting 5 or more joints. Systemic JIA is the weird one. It starts with systemic stuff, like high-spiking fevers and a rash, not so much the arthritis at first. And lastly, enthesitis-related arthritis, which affects where tendons and ligaments attach to bone, and it's heavily associated with HLA-B27. And these images, wow, they just perfectly illustrate the key findings in Kawasaki disease. You have to recognize these signs: the strawberry tongue and the red, cracked lips. Remember, the diagnosis is clinical. It's based on having a fever for at least 5 days, plus 4 out of 5 other key criteria: that bilateral non-pus-filled conjunctivitis, a rash, swollen lymph nodes in the neck, these changes in the mouth, and changes in their hands and feet, like swelling or peeling. This is a diagnosis you cannot afford to miss. Okay, time to shift gears from inflammation to inheritance. Section 3, decoding genetic principles. You know, genetics provides the fundamental blueprint for so many conditions we see every day in pediatrics. Let's start by cracking the code on pedigree charts. Take a look at this classic example of autosomal dominant inheritance. What are the dead giveaways? Well, first, the trait shows up in every single generation. It doesn't skip. Second, if you're affected, you have a 50% chance of passing it to each of your kids. And third, it affects males and females pretty much equally. Now, let's contrast that with autosomal recessive inheritance. The biggest clue here is that it skips generations. You'll often see affected kids born to parents who are totally unaffected themselves because they're both just carriers. And like dominant inheritance, it hits males and females equally. And here's a key connection. This is the inheritance pattern for most of those inborn errors of metabolism we're about to talk about. And our third major pattern is X-linked recessive. The key feature here, it almost always affects males. And why is that? Well, because males only have one X chromosome. The condition is usually passed from an affected grandfather through his carrier daughters to half of his grandsons. Classic examples are things like Duchenne muscular dystrophy and hemophilia. Now, beyond these single gene problems, we've got these large-scale chromosomal abnormalities. This picture is a karyotype. It's basically a visual map of someone's chromosomes. And you can clearly see, count them, 3 copies of chromosome 13 instead of the usual 2. This is trisomy 13, a perfect example of aneuploidy, which just means an abnormal number of chromosomes. This is totally different from a structural abnormality, like a translocation, where you have pieces of chromosomes that are just in the wrong place. And that leads us perfectly into our third topic, Section 4, approaching metabolic errors. As we just said, a lot of these are genetic. Now, the key here is not to try and memorize 100 different diseases. Instead, you need to have a systematic, problem-solving approach when you're faced with a really sick child. This flowchart is your absolute best friend, so let's just walk through it. Imagine you have a newborn who was perfectly fine at birth but is now acutely unwell. The algorithm starts with 3 basic lab tests: plasma ammonia, a blood gas to check the anion gap, and urine ketones. So let's follow the path. Is the ammonia level high? If yes, then look at the anion gap. If that anion gap is normal, you should be thinking this is probably a urea cycle defect. But if that anion gap is high, it's much more likely to be an organic acidemia. See? This systematic approach will get you into the right ballpark almost every single time. Okay, let's clear up a really common point of confusion, the difference between gray and white matter diseases. Think of it this way. Gray matter diseases, like Tay-Sachs, mainly affect the neurons themselves, the processors. They tend to show up with early and pretty severe seizures and cognitive decline. On the other hand, white matter diseases, the leukodystrophies, affect the insulation around the nerves, the wiring. They usually present with motor problems first, like spasticity and ataxia, with the seizures and big cognitive problems coming much later. The timing of that first symptom is really the key. Excellent, you're doing great. Let's pull all of this together now in our final section, the high-yield integrated review. This is where we're going to really solidify these connections and point out some common exam traps. So here's a classic point of confusion, a common exam scenario. A child comes in with a single swollen, hot joint. Is it a bacterial infection or is it just sterile inflammation? Well, the synovial fluid analysis gives you the answer. In septic arthritis, the fluid is going to be cloudy, the gram stain might be positive, and, this is crucial, the glucose will be low because the bacteria are literally eating it. In an inflammatory arthritis like JIA, the fluid is clearer, the gram stain is negative, and the glucose is usually normal. It's a simple test with huge implications. Okay, time for a rapid-fire review. Let's lock in the rheumatology takeaways. First and foremost, always classify arthritis by duration. Is it acute, subacute, or chronic? For JIA, you've got to know the patterns. Oligoarticular is linked to uveitis, and systemic disease starts with that high fever. And for Kawasaki, it all comes down to that 5-day fever plus those classic signs like the strawberry tongue and red, cracked lips. For genetics, what do you absolutely need to remember? Get really good at spotting those inheritance patterns on a pedigree. Dominant doesn't skip, recessive does, and X-linked mostly affects males. And you absolutely must understand the difference between aneuploidy, which is a number problem, like the trisomy 13 we saw, versus a structural problem, like a translocation. And finally, your approach to inborn errors of metabolism. When you see a really sick newborn, your first-line tests are always going to be ammonia, blood gas, and ketones. From there, it's just about interpreting the pattern. High ammonia with a normal anion gap points you straight to a urea cycle defect, while high ammonia with a high anion gap should make you think organic acidemia. Just trust the flowchart. So, there we have it. In a pretty short time, we've gone from the clinical patterns of joint pain all the way to inheritance blueprints in genetics, and then into the biochemical pathways of metabolic disease. You can really see how having a structured, pattern-based approach is the absolute key to making sense of it all. So as you continue with your studies, just try to remember this one simple idea. Master the patterns, not just the pages. It's those connections between the topics that will truly cement your knowledge and really help you excel.